Hello, everyone. First, I would like to thank the organizing committee for inviting me to be part of this meeting. Here are my disclosures for research support, advisory board, and editorial board positions that I had. Nothing is related to the content of this talk. So I currently practice at Duke University, which is in the southeast coast of the United States in North Carolina. We have a high-risk labor and delivery unit. We have over 4,000 deliveries per year with a high epidural rate of 80 to 90% and a high cesarean rate as well of about 40%. Our group has 11 fellowship-trained obstetric anesthesiologists who provide 24/7 coverage to this high-risk labor and delivery unit. So this talk addresses the role of the obstetric anesthesiologist in reducing maternal morbidity. And there are many areas where we can contribute significantly to reducing maternal morbidity, but I chose to focus on four of these areas for this talk. So here's the outline of my talk. First, I'm going to present current data on maternal morbidity and mortality, and then I'm going to talk about the role of the obstetric anesthesiologist in reducing morbidity associated with hemorrhage, cardiac disease, hypertensive disorders of pregnancy, and mental health conditions. So let's first talk about maternal morbidity and mortality. Medical advances has allowed women with severe medical conditions, some of which used to be contraindications for pregnancy, to carry pregnancies to term. In vitro fertilization techniques also permit older women, some of which with chronic medical conditions, to become pregnant. Therefore, we are looking after an increasingly high-risk obstetric population who are older, sicker, have multiple comorbidities, more cardiac disease in pregnancy, and the rising cesarean delivery rate results in more cases of placenta accreta spectrum with its associated morbidity. Throughout this talk, I'm going to talk about severe maternal morbidity, or SMM. So I'm going to introduce the concept here for those who are not familiar with it. Severe maternal morbidity, or SMM, is defined by the U.S. Center for Disease Control and Prevention, or CDC, as unexpected outcomes of labor and delivery that result in significant short or long-term consequences to the individual's health. To identify delivery hospitalizations associated with SMM, the CDC uses administrative hospital discharge data and International Classification of Diseases codes to identify 21 indicators of SMM that you can see on this table here. This was a US study that looked at SMM according to maternal comorbidities. And this study found a dose-response relationship between the number of comorbidities and the risk of severe maternal morbidity, or SMM, across all racial groups examined in this study, with the highest rates of severe maternal morbidity among women with 3 or more comorbidities, something that we see not infrequently in our practice. This was another study that looked at the rates of SMM over time in the US from 2008 to 2021. As you can see here, there was a steady increase in the rate of SMM over the time period of the study, and the increased trend was observed in all age groups, with the greatest change observed in patients 45 years or older and those who are 10 to 19 years of age. This increasing trend of SMM is not unique to the US. These are data from the UK also showing increasing trend of SMM over the duration of the study from 2004 to 2018, with higher rates in older women. This was a study that looked at global causes of maternal mortality from 2009 to 2020 and reported that hemorrhage remained the largest cause of maternal death globally, followed by indirect causes, followed by hypertension. These are the most recent data about pregnancy-related death in the US, covering the years 2017 to 2019. And as you can see here, mental health conditions have emerged as the leading cause of pregnancy-related death during this time period. This was followed by hemorrhage and cardiac coronary conditions. And interestingly, 84% of those deaths were deemed preventable. Here are some data from the UK, the most recent data about maternal mortality in the UK, covering the years 2020 to 2022, showing that thrombosis and thromboembolism were the leading cause of maternal death in the UK during this time period. And the second most common cause of maternal death was COVID-19. If we look at direct causes after thrombosis and thromboembolism, the second most common direct cause of maternal death was suicide, similar to what we saw in the US. This was followed by obstetric hemorrhage and sepsis. Looking at indirect causes after COVID-19, the next leading indirect cause of maternal death were cardiac disease and neurological conditions. So we've seen here globally and in developed countries, hemorrhage and cardiac disease play a significant role in maternal morbidity and mortality. So let's first talk about the role of anesthesiologists in reducing morbidity associated with obstetric hemorrhage. And I'm going to show you here 3 studies. The first study was published in 2018 from France, covering the years 2004 to 2006, and included a patient population who had postpartum hemorrhage due to uterine atony. And the primary outcome of the study was severe postpartum hemorrhage, which was defined as hemoglobin change of 4 grams per deciliter. And this study found that the presence of epidural analgesia was associated with a 47% reduced risk of severe postpartum hemorrhage. A more recent study from the US, published in 2022, included patients who had their first vaginal delivery, and the primary outcomes were SMM and postpartum hemorrhage. And in this study, the presence of epidural analgesia was also associated with a 14% reduced risk of SMM, and the decreased risk of postpartum hemorrhage accounted for the 21% of the protective effect of epidural analgesia. Finally, a study that was just published last year from the UK included women who had vaginal or cesarean delivery. The primary outcome was SMM and SMM with ICU admission, and similar results were reported here. The presence of epidural analgesia was associated with 35% reduced risk of SMM and 54% reduced risk of SMM and ICU admission. And in this study from Scotland, they analyzed the data based on whether there was a medical indication for epidural analgesia and whether the patients were preterm or term. And they defined the medical indication for epidural analgesia as any serious cardiovascular or respiratory disease, preeclampsia, previous cesarean delivery, breech presentation, multiple pregnancy, and morbid obesity. Basically, all those patients who have a medical condition for which we should encourage and in that patient to receive epidural analgesia because of the medical benefit associated with it. And what they reported here, that the protective effect of epidural analgesia was significantly more pronounced in patients who had a medical indication for epidural compared to those who did not, was more pronounced in those who had a preterm birth compared to those who did not, and the greatest reduction was associated in patients who had both a medical indication for epidural analgesia and preterm birth. And this benefit and protective effect was seen along the 3 outcomes of SMM and critical care admission, and respiratory morbidity. So we as obstetric anesthesiologists have a very important role in identifying these women who will benefit most from epidural analgesia and make sure that we communicate with our obstetrician and nursing colleagues and make sure that these patients received their epidural analgesia. So how does the presence of epidural analgesia reduce morbidity associated with postpartum hemorrhage? Well, when we have an epidural analgesia in place, it's much easier to quickly escalate to the venitive obstetric interventions because we can provide adequate analgesia for those patients so that the obstetrician can provide their definitive obstetric interventions. Those patients are also under close oversight by the obstetric anesthesiologist. They have hemodynamic monitoring in place. They have an established IV access and fluid administration going on, so it's easier to escalate resuscitation in these patients. Also, the presence of epidural analgesia blunts the stress response to labor, which is very important in patients with cardiovascular and respiratory disease. And finally, the presence of epidural analgesia allows for easier conversion of analgesia to anesthesia if cesarean delivery is needed, and therefore avoiding the risks of general anesthesia and the morbidity associated with it. Here is the hemorrhage protocol that we have here at Duke. We have 3 stages based on the amount of blood loss and hemodynamics. And we have this protocol that outlines the role of each provider. So when a hemorrhage happens, the nursing staff will send a page out. The anesthesia provider reports to the bedside. We assume the primary responsibility for managing resuscitation. We provide analgesia to facilitate obstetric interventions. We become the primary point of contact with the blood bank and for receiving labs and add additional lines as needed. Here is the second stage of labor. Also, second stage of hemorrhage. We are also at the bedside and we continue to take the responsibility for managing the hemorrhage, provide analgesia, insert an arterial line if needed, transfuse as needed. And here is stage 3. We communicate with the obstetric providers whether we need to transfer to the operating room and continue to manage resuscitation in these patients and then call off the protocol when this is no longer needed and the patient is adequately resuscitated. So we really take a primary leadership position in managing these hemorrhages, and we send labs every 15 minutes, and these labs are communicated directly to us. The labs personnel calls us on our phones to notify us of the results so that we can manage resuscitation accordingly. Now let's talk about our role in reducing morbidity from cardiac conditions. And as we saw, cardiac disease is one of the leading causes of maternal morbidity and mortality, and the specialty of cardio-obstetrics has emerged in response to the rising rates of maternal morbidity and mortality related to cardiovascular disease in pregnancy. Here you can see the role of the pregnancy heart team, which is a multidisciplinary cardio-obstetrics team involving a core group of a cardiologist, obstetrician, anesthesiologist, and special nurse, clinical nurse specialist with other specialties added as needed. And this team ensures appropriate monitoring during pregnancy, during plan for labor and delivery, and ensure close follow-up during the postpartum period when cardiovascular complications remain common. This team also looks after the patient pre-conception and ensures longer-term follow-up of those patients. We have a heart team at Duke. This is the information that we have in our website to highlight to our patients. And in this website, we highlight the important role of the obstetric anesthesiologist in deciding about what monitoring is adequate, what is the best location for the patient to deliver. Is it in the labor and delivery unit? Is it in the main OR, in the cardiac OR? Do we need ECMO on standby? And we also play an important role in analgesia, in planning of the anesthetic management of those patients and planning for where to care for them postpartum in conjunction with our obstetric and cardiology colleagues. Our pregnancy heart team meets once a month. We go through this checklist, we complete for every patient, and then the care plan is uploaded to the electronic medical record so that anybody looking after those patients will have access to the plan that was formulated by the pregnancy heart team. Next, we'll talk about hypertensive disorders of pregnancy and obviously our expertise in point of care ultrasound, cardiac ultrasound, and lung ultrasound facilitates management of those patients. We should encourage neuraxial techniques for those patients. They are strongly preferred for labor analgesia. They reduce oxygen consumption and minute ventilation during the first and second stage of labor. And the presence of epidural analgesia also improves intervillous blood flow and decreases maternal plasma catecholamines. The American Society of Anesthesiologists guidelines recommend early epidural analgesia in these patients even before the onset of labor to reduce the need for general anesthesia in emergent cases, in addition to the benefits that I already highlighted. So it's really important to avoid general anesthesia in those patients. This was a study that looked at the differential impacts of modes of anesthesia on the risk of stroke among preeclamptic women who undergo cesarean delivery. And this study found that the stroke-free survival rate was significantly lower in preeclamptic women who received general anesthesia when compared to those who received epidural or spinal anesthesia. And this was actually true over a 6-year period after the index delivery. Obviously, with general anesthesia, there is stress response to intubation and extubation, which can increase the risk of stroke. And there were no differences between epidural and spinal anesthesia. Finally, I'm going to talk about mental health conditions. As you can see, this emerged as important leading causes of maternal death in the US and the UK. Currently, postpartum depression occurs in up to 17% of patients. Childbirth-related post-traumatic stress disorder is reported in up to 6% of patients, and post-traumatic stress in up to 12% of patients. And there are a number of factors that contribute to childbirth-related post-traumatic stress, including antepartum complications, lack of social support, pre-existing mental health conditions, adverse life experiences. But the one that is really most important and we have influence on is the negative childbirth experience. The American Society of Anesthesiologists issued a statement on providing psychological support for obstetric patients and highlighted peripartum events contributing to trauma. And as you can see here in this table, some of those are directly under our influence of obstetric anesthesiologists, including pain during cesarean delivery and neurological complications such as nerve injury and post-dural puncture headache. And then they provide recommendations for providing psychological support for obstetric patients, 3 domains of sovereignty, support, and sharing. In the domain of sovereignty or sense of control, include minimizing use of upper extremity restraints, shared decision-making regarding the use of anxiolytics. For support, maintaining vigilance in efficacy of neuraxial techniques, promptly identifying inadequate analgesia or anesthesia and addressing it, respect modesty, and prompt evaluation and active management for patients of post-dural puncture headache. And in the domain of sharing, continue conversations and initiate them with the patient so that the patient and the provider agree on their anesthesia care goals and plan for action for managing their needs, taking care to explain care management plan, especially in emergency situation, and provide transparency surrounding events and follow up if complications arise. In addition of all what I have already mentioned, the American Society of Anesthesiologists has issued a statement on anesthesiologists' role in reducing maternal morbidity and mortality and highlights a number of areas where the anesthesiologists contribute significantly, including the levels of maternal care, the SOAP Centers of Excellence, the being members in the Alliance for Innovation on Maternal Health, being members of the state maternal mortality review committees and the obstetrical perinatal quality committees, establishing antenatal anesthetic consultations, and being a member and leading multidisciplinary simulations on the labor and delivery unit. So I will end with that. So definitely we play a significant and important role in reducing maternal morbidity and mortality, and I look forward to your questions. Thank you for your attention.